Fine, start, please.
Hello, I'm Dr. Henry, one of the duty doctors today. May I please confirm your name and age, please?
Yes, doctor. Mr. Oliver Smith. I'm 28 years old.
Okay, I understood you have been wanting to see me. Is that
No,
so?
doctor. No.
Okay, actually, I've come to discuss concerning your health condition with you, if you don't mind. Is this setting okay for us to discuss?
Okay, you can.
Right, okay. And just to, how are you feeling now? Are you feeling much better now?
Much more better, doctor. I'm feeling
Oh,
fine, and I don't know. I mean, why I'm in the hospital. I can go home.
yeah. That's a that's you, that's a good question. Actually, the reason why you are in the hospital is concerning you are not feeling so well, and you are admitted, on account of the fact that you took
So, what
some
do you mean
some
by that?
type. Pardon?
I mean, what you just said? Can you repeat it, please?
Um, you asked why you are in the hospital, right?
Yeah.
Okay. The reason why you are admitted in the hospital was because of the fact that you took some medications of paracetamol. Is that true?
It's true. I mean, I was feeling really low, and I just want to vanish my life, doctor. I was feeling, to be honest, very low. I recently lost my job. My wife left me. My finance completely ran out. I don't think, I mean, my life is over to live. That's why, but I'm feeling fine now. I just want to go home, doctor.
I can see, I know that you are passing through a difficult time at the moment, but not to worry. We'll see how we can help you out, even with your discharge, and then with your overall health condition. Is that okay, Mr.
Yeah, that's
Olivia?
fine, but I don't see any point to discuss anything right now. I'm feeling completely fine because no one helped me in my first 6 months. I was able to run out everything. I don't see any kind of help is coming in my life. So I don't see any point to stay in the hospital as please
Um,
help me to
um,
go out of the
I,
hospital.
I know this might be frustrating for you at this moment. I'm sorry for all that has happened to you so far, and all that you have been passing through. But I want to assure you that with if you can be patient with me, we can address all your concern. I'll be happy thereafter. Is that okay, Mr. Oliver?
I can't trust anyone. I'm afraid that if I share anything with you, probably will disclose it, doctor.
I see, I see. It is completely normal for you to feel this way, Mr. Oliver. But I want to assure you that our meeting is strictly confidential, and we'll see. And the reason why we are meeting today is to ensure that you are better than the way you feel previously. Is that okay?
Yes, doctor. But what
Okay.
about my condition? So far, I am feeling fine, doctor. Is it fine? Okay, I want to go home, doctor. I'm completely fine.
It's a good news to know that you are feeling much better now. Because actually you had you have been managed as a case of overdose of paracetamol, and paracetamol as is that you took
Yeah.
is yeah was the paracetamol that you took appears to be very dangerous to your health system. And what we did was to mop up some of the dangerous parts of it, but we have not completely mop it out. We give you a medication that prevents further worsening of your health condition, because paracetamol poison can affect the liver, can affect
Hmm.
the kidney, and if not treated very well, can also cause death to the individual. So
But in
what we
my
did
case,
was,
probably I'm pretty fine and out of danger, doctor. What do you think?
actually it appears so, and that's the good news. But the treatments is not complete because after we've given the first dose, we are supposed to give you another one to ensure that all the harmful element or the harmful substance that you consume is completely clear off. And after which we are to do some tests for you. If after we've done the test and we notice that your blood is completely cleared off of this harmful substance, then you can be free to go. How about that?
That's fine, but as you said, I'm feeling fine, and your doctor gave me some medication, and since then I'm feeling fine, doctor. And if anything I feel bad, I will come to the hospital, doctor, because I'm very concerned about other part as well.
Yeah, your concern is absolutely understood, Mr. Oliver. Like I previously mentioned, what we did was we give you the first part of the treatment. If we stop at this point, you are at risk of coming down with a far more harmful condition, a far more danger. You are putting yourself at a far more harmful condition than you were previously. So because the treatment is in different form, given the first one, we have to repeat another one and then repeat the test, then monitor. Because if we allow it to go at this point in time, you are at risk of having further kidney damage and further liver damage, which may appear normal now, but sometimes it might present as maybe confusion, bleeding excessively.
So how long I have to stay in the hospital, doctor, to be in safe side?
Yeah, your question is valid, Mr. The duration you have to spend in the hospital as it is, I cannot categorically tell you until we do the test and it shows that you are completely free of this harmful substance of the
Okay, so after evaluating the harmful substance completely washed out from my body, probably you will allow me to go home, right? Because I'm very concerned about few other points, as I'm almost able to run my finance, okay? And this hospital is very costly, so it's really tough for me to stay in the hospital, doctor, and manage the cost of this treatment.
Yeah. I quickly understood what you've said so far. This is what we intend to do for you as part of the next step. What we intend to do for you now is to involve all the necessary team that will be involved in your case, which will involve the social services that will help you to ensure that your fund, because we noticed that you've not been you have this fear of paying your bills, but we'll discuss with our social services in the hospital, which will help you in that regard. And then because of the fact that you have been experiencing some difficult times that has been affecting your mood, also may also involve our mood doctor to also see you. And then
Doctor, hold on. Do you think I'm a mad person? You are involving the mood doctor. I'm completely fine. I was just feeling low. That's why, out of my emotional outbreak, I just took the dose of the paracetamol. But I'm completely fine, doctor. Why you are involving the mood doctor here? Is it really necessary in this case?
Mr. Oliver, to be candid, the reason why we are involving the mood doctor is not because we have any maybe mental health condition, no, but it's because of the fact that they can able to manage your emotional problem you are having perfectly well. They are specialized in doing this, and they can help you out.
But do you think I'm a mad person, doctor?
No, not at all, not at all. Forgive me if it sounds like that. No, but what they do is that they help you to ensure that your emotional state in terms of the way you feel becomes okay. I don't know if that would be okay for you, Mr. Oliver.
No, I'm very concerned about that. Why you are involving the mood doctor? I'm pretty completely fine, and there is no problem in terms of my mental health. Are you thinking I'm a mad? So that's really very concerning me. And at the same time, I'm very concerned. Okay, if you inform the mood doctor, probably it will take more time to stay in the hospital. I'm very concerned about that.
It is quite valid that your concern, but what we do is that the mood doctor, after seeing for the first time, they can give you some appointment depending on the outcome with their meeting. They can have one-to-one meeting with you if it's at home or probably on your next appointment visit. But I think it's important for them to assess you so that you will not come back with similar effect. Thank you very much.
Thank you.
All right.
Okay, Dr. Henry, how does it go?
It was okay. It was okay.
Fine. Anything you could have done differently, or anything you want to address more if you are allowed to keep more time?
Yeah, there's a lot of things I wanted to address, but like
For
it's
example,
there's no way it can be complete. One of the things I want to address, because since he's willing to, if he has finally accepted to stay in the hospital, then we need to start the ask
Mhm.
about. I mean, we need to ask about his other. Whom does he empathize as? Whom does he live with? The kind of job he's
But
doing,
I mean,
and
you're trying to assess his social life and family
yeah,
part, right?
yeah,
But apart from this, any other things you think, I mean, very important is related to the case, but you could address?
yeah. Safety netting. As
What type of safety
then,
netting?
yes, since he's currently having the if other symptoms of worsening of the condition, such as problem with confusion, bleeding excessively, problem with urine
Okay,
problem, down to
fine.
the effects of the kidneys. Yeah.
Yeah, fine. Okay, before going to the feedback part, I would like to interact with the other candidate. Okay, this is, by the way, a very tricky scenario in a sense that it's not usual, follows the usual format of the conversation. So we have to go a little bit deeper. And um, so in that sense, it's a little bit atypical. So I would like to know anyone has any important comment on the point or calibration we did not, or Dr. Handy did not touch, or we could address more, or anything Dr. Handy did miss, but it should cover in this type of scenario. Anyone has any important point, you can unmute yourself and can add your point. Then we'll go to the feedback part.
Assessments of a depression in this case.
Sorry, assessment of the Dr. Hassan?
Depression.
Assessment of the depression,
Is it-
right? Yes, fine. Yeah. It's
And the
valid question.
second thing,
Mhm.
he can arrest under mental
Sorry,
substance. Can
intermental
be arrested under mental, yes.
employment. I'm not getting you properly. Okay. Yes.
She can
I mean,
arrest under mental action, no?
mhm. Okay, fine.
Okay.
Yeah. I mean, the point we need to address in this case, by the way, and that the scenario is suicidal case, and in this type of scenario, we have to follow a little bit atypical pattern as well, and it is better to start from the end part of the scenario. For example, social history, how, I mean, with whom they are living with, what do they do, and what is their financial, I mean, stand. These are the things actually triggering them to take their decision like suicidal attempt. So that's why it is better to start from the end part. And by starting a little bit atypical in a sense, you have to be very, very soft, very slow at the very beginning, seeking their, I mean, full formation, giving the hope and reassurance that every information they are going to be shared with us as a doctor will keep it completely confidential. And that kind of approach will give the, I mean, complete hope and trust, and only then patient will disclose everything. And by the way, in this case, Dr. Handy, you later on, I mean, said that, okay, we'll keep everything confidential, but the approach should be at the very beginning. Otherwise, the patient would not disclose anything, because patient is completely, I mean, shaky and broke in every possible way. Life hit them in from every possible angle. And now they can't trust anyone. Even the concern of this staying in the hospital and financial part also just keep them on the stress mode, right? That's why he's very concerned. I just want to leave the hospital, because they are very concerned about the financial part as well. As you can see, it is written in the scenario, right? If you look at the scenario part, like, they're very concerned about the cost of the stay in the hospital. So this part also needs to be addressed. And now coming to the point, how the typical starting can be. In a case of suicidal case, you have to start with a approach with, okay, hello, I'm Dr. Islam or Dr. Henry. I'm one of the doctors in the Mood Clinic. Okay, am I talking with Mr. Oliver Smith? As your studying was completely fine, but the second sentence could be, Okay, what we are going to discuss, everything would be confidential and on record. Okay, no one will know that, and only upon your permission we can disclose or anything like that. But just one sentence, everything we are going to discuss would be confidential. Okay, can you tell me how are you feeling today? Then patient will disclose probably gradually. Okay, I'm feeling fine and I just want to go home. But going to deeper, you have to raise the issue of suicidal part and avoid this issue in a very sensitive way, in a very non-objective way, in a way that is not direct and judgmental. How you can say that? You can say from the case note, not as a doctor. From the case note, we came to know that last night or a few hours ago, something happened with you, which is completely unexpected. It means you're not saying something completely directed to the paracetamol or something else. So you're just saying something and checking at the same time, do they have this idea what actually happened, what actually brought them to the hospital? Probably they were drank or probably found by someone on the street they brought into the hospital. So that's why they might not have the idea what actually brought them to the hospital. So that's why you can say, from the case we came to know that something happened to you, which is completely unexpected. Do you have any idea? No, doctor, I don't have, or probably have. And based on their knowledge, you can, determine your next move. In this case, patient has some idea and patient is trying to hide something because they can't believe anyone because they are nearby and loved one completely left them in a very broken way. Life hit them repeatedly, so they can't trust anyone. So that's why they try to freeze it something or just keep it hide. Then you have to unfold it one by one. Okay, I came to know that from the case note, you took some tablet. Am I right? Keep some pause. And by the way, golden pause is not only designed to break the breaking bad news. You can apply it in this scenario particularly. You have to very slow in a very soft and very polite and very non-judgmental in the beginning. Then you can really pace up your scenario. Then they will say, doctor, yes, I took some tablet. I just want to vanish my life. I don't feel my life is worth to live. I'm feeling low. My wife left me and just broke up with my family. I'm financially completely nowhere. I just lost all of my money. Okay. So that's why I don't think to live my life. That's why I just took the tablet. I just want to vanish my life. Then you can take the full control and wheel of the scenario. So how you can take this? You can say, Mr. Smith, I'm so sorry to hear that you're going through this type of difficulty and tough time. And you're not alone in the journey. We are here to help you from every possible angle. And life sometimes hits every one of us. Sometimes the things we plan doesn't go according to our plan. Yes, it happens to everyone. And in that moment, we take some decision on the peak of the emotional outburst we never planned for. And in your case, probably you try to take some, medications and try to do something. Is it something like that? Am I right? Then patient will say, doctor, yes, I took these things and I would like to just complain and finish my life. And that's why I did it, doctor. But I'm feeling fine. Now, the second part, to check the assessment. The assessment of what? Patient took some overdose medication. Let me take fresh slide. So the first things you just verify the fact from the patient's point of view or from the note in a very non-objective way, okay, or non-judgmental way. Now, first things you check the fact and give the baseline. Okay, now checking assessment. The second part is actually assessment. Assessment of what? Assessment of the situation. Pre, during, and post. Okay, that part was completely missing, Dr. Henry. You could spend some time in this part, okay? So, Mr. Smith, I already say that what you will share, everything would be confidential, would not disclose anything. May I know what actually happened? We can help you. Believe me, we are not here to judge you. We are going to help you to come out of the situation. What actually happened? So I took number of tablets, okay, probably 20 or 10. Okay, then your question should be, do you take all the medication at a time? So at a time, I mean, all the medication at a time, one of the checklist. Then do you take any other medication apart from this paracetamol? So it can be alcohol or other medication. So it's very important to ask that to check the severity. Okay, so and why you actually why actually you took this medication? During the taking the or incident, did you just lock the door if it is in their home or their apartment? Did you just lock the door? So during the things, you have to take something, some history. During the episode, did you lock, or during committing suicide, did you lock the door from inside? So door related history is very important. Did you write anything, any suicidal note? Okay. Why this is important, Dr. Henry? If they, I mean, locked from inside, wrote something that no one is responsible for my life, it means they're really committed. And in that case, they, I mean, should be evaluated mood doctor in a very, very, I mean, prompt way. So this type of assessment actually help us to know their, I mean, intensity and degree of their intention. Okay. Then, okay, during the, I mean, committing suicide, did you feel any repent, or just after following taking the medication, did you feel any repentance, or that you did something wrong? This type of question is very important. Okay, then you can say, okay, do you have any other mood problem? It's very important. And according to the, I mean, rider and also NSS guideline, when someone just presented with a suicidal problem, one question you have to ask in a very non-judgmental way, do they have any past mental problem? In a way, I mean, mood problem. Do you have any mood problem? No, doctor, or yes. Any other family have the same kind of problem? You have to ask that. Although it's a communication scenario, but this type of question is very important. Then you can go to the main part. Okay, we started the treatment. Now you're feeling fine. That's really great. But you need to stay in the hospital to be in safe side, and we're monitoring your vitals. Okay, doctor. Then patient will say, no, doctor, I just want to go home. Why? Why they want to go home? Because I said twice. And later on, probably, Dr. Hand, you discover that there are some financial crises and issues, and concern is related here. Then you meet the concern, and by involving the social workers. But I think you should, I mean, seal it off at the very beginning when they just saying they don't want to stay in the hospital. Why? The answer can be two. 2A, it can be something they're trying to avoid in the hospital, or something is attracting to the home. Probably they are now in a repentant state. They completely regret for their actions, but now they're thinking, okay, I have a pet in the home, no one is there to feed him. Okay, I have to go home. This is something attracting their home, or they're trying to avoid something. In this case, they're trying to avoid the financial crisis or financial problem, as they don't have any money. He does not have any money. So that's why he's trying to avoid that, right? So you have to completely seal it up with a, I mean, multidisciplinary approach and help. Again, this is completely, I mean, a government hospital, or you can say the insurance will actually carry the cost. You don't have to worry about that. And there is a very good team, social workers, they will help you and manage the every possible concern you have. Okay. So even in NASS, if someone is very concerned about their partner or lacking the partner, in that case, there are matrimony or marital counselor is there. So there is no other things that NASS cannot support with, okay? They have various different support systems. Then when the third part of the conversation, doctor, I'm pretty fine. I would like to go home. Why you want to keep in the hospital? The first part you just explained that drug we gave, I mean, that completely reverse your symptoms, you're feeling fine. Still, we have to monitor it for a few hours because the liver damage feature may appear on the later part. That's why we need to. In the meantime, we hope that drug you took washed out from the body, right? This is the first thing. And second thing, as you are going through some mental trauma, low mood, recently broke up, financial problem, or you would like to help you. How? By involving MDT. And in the MDT, there is a team member we call mood doctor. And as you know, it's a very paid and common questions you are going to deal with when you involve the mood doctor. The common concern will come, doctor, am I mad? Do you think I'm mad? Why you are involved with the mood doctor? So be prepared until the sentence in a way you don't have to face this kind of question. So how you can present, okay? So we're going to involve a multidisciplinary specialist panel, one multiple team of doctors and social workers will there. They will help you in terms of the finance and elevate your mood. And by the way, don't wait for that. By the way, mood doctor is one of the doctor who is one of the doctor and part of our team. They will talk to you, try to assess your, conditions, give up, have some talking session and boost up your confidence. And they also help you to train how to deal with everyday stress. And by the way, you are not, away from it. Everyone go through some stress. And by talking to the mood doctor, you are going to have this type of benefit. And then probably patient will think about, okay, is it mood doctor means, I'm mad? Or probably they will be happy with your answer. So your answer will determine everything, okay? So before saying the mood doctor, just explain few things. What actually the objective of the involved in the mood doctor. Mood doctor will elevate your mood. They will train you how to deal with everyday stress, okay? And this is how the doctor is going to help you, okay? Then you can say the social workers team are very, very supportive. They will also help you to manage your, everyday expense or budget, or they will also help you in terms of the home and other type of support. So this type of, things could be a little bit elaborative in your case. In the last moment, yes, you explored that. But I think the pre, during, and after assessment was a little bit less because it is very important to assess that. Otherwise, the scenario would not be complete. So, Dr. Handy, are you with me?
Yes, I'm with you.
Okay. So, for any questions from your side?
No. Noted.
Okay. So, anyone has any questions so far?
Sorry, one more question. Sorry. Like in this scenario that it was stated there that the patient wanted to see me or have a word with me. Is it also right where I started, saying that I was understood you, or probably I was informed you want to have some words with me, or because it was stated in the scenario that the patient wants to talk to me. It was one that is.
Sorry, can you just repeat the question again, please? I did not get it.
If you can, in the scenario, if you can put the scenario again, let me show you something. The scenario.
Yes. Yes. Yeah. This is the scenario.
Okay. If the last statement say now he wants to talk to the duty doctor.
Yeah.
To accelerate. So now it's like I'm assuming that when I was trying to do the setting that he wants to talk to me, not me want to talk to him. I don't know if that is okay because in the scenario it was stated that he was the one that wanted to talk to me, and that was why I'm coming to see him.
The patient don't want to talk to him. And there are a number of concerns there. Probably they are thinking there are financial issue. Probably they have to be on the line for a long time, and probably they are not going to get any benefit from them.
Sorry, no. What I was trying to say is that this in the scenario, the patient is the one that is wanting to talk to me. So, like in my approach, I started by saying that I believe he wants to have some words with me, or probably some discussion as regards to his discharge, I think that was where I started it. I don't know if that is okay.
Yes,
My
I mean,
introduction. I'm
I mean,
just kind of confused.
in terms of the introduction is fine. What I'm trying to say during the last moment, if you just involve, and definitely as a task, but you have to involve the mood doctor, it's your part. Then probably they will come up with the, consent doctor. No, I don't want to talk with the mood doctors. I'm completely fine. But you have to explain why it is important and what are the benefits they're going to have after talking to the mood doctor. And by the way, they have some stigma, false misbelief that probably more doctors will ask about few other things as I don't have. It will take some time or some financial cost is involved here. These are the things probably running in the patient's mind. That's why they don't want to talk with the mood doctor. But you have to remove the stigma. The mood doctor is not on the doctor only for the mad people. And by talking with them and having a session with them, probably you'll feel better. They will train you how to deal with the everyday stress. And in this case, by the way, by raising this line and adding this line, there are, one important, things is coming into the equation. And examiner will check, okay, actually, as a candidate, you are about these things or not. Because if they really want to go home without having a consultation with the mood doctor, in that case, as a doctor, you are bound to keep them. The legal duty. Because when someone actually tried first or second time commit suicide, in that case, they are not mentally sound until proven otherwise. They have to undergo a baseline mood assessment or psychiatric assessment. And as a doctor, we cannot say in a strict way to the patient, you have to try in every possible way to convince them. If they are not agree with your plan, in that case, you have to be a little bit strict from the objective point, okay? Mrs. Smith, I'm sorry to tell you, okay, without a baseline, mood assessment and quick chat with the mood doctor, we cannot let it go. But it actually depends on how you are well convinced and how you are actually trying to convince the patients in your way. And an ideal calibrated candidate and surrogate will actually agree with your plan. And they will say, doctor, if you arrange in a very quicker way, in that case, probably I would agree with your plan. And this is how you can end up the scenario. And if they're very hurry, you can even have two options. You can immediately arrange meetings with the mood doctor. You can have a tele consultation on online, but you have to show the pathway to the examiner that, yes, I am well-oriented. I can come up with a solution, but I did not give up. That patient and did not completely give up with my approach. That patient said, I want to go home, and you just let go. No. At least you have to show your way that, yes, you offer telemedicine consultation, teleconsultation, you invite immediate meeting with mood doctors. Yeah, that's the part actually we're trying to practice by mentioning this line. Yeah. Fine. Any questions regarding this scenario?
Thank you.
Yeah. So in this type of scenario, this is the format I just built from, it can be applicable to different type of scenario. The different type of scenario means committing suicidal case type of scenario. So first of all, start always with the check and well-being, how they're feeling now. This is a very good starting. And you can ask about, based on the symptoms, if you can ask about how they are feeling, if they have any tummy pain or your discoloration of the skins or headache, you can ask about that. Then determine the history of the self-harm, okay? Before, during, and after. These are the questions. It's the general questions applicable to different scenario, but you have to at least go through pre, during, and after assessment as a safe doctor to check the checklist to understand their, severity of the intention, okay? And if they don't have any regret, or probably this is their second attempt, in that case, the mental assessment is a must. They cannot skip, and your position is very strong in that case. Yes, I'm going to involve the mood doctors. They will have a quick assessment on you, and then you can go home. After any regret, okay, any loss of consciousness or anything, you can ask. Probably loss of consciousness is applicable for glycoside, something like that, glycoside induced hypoglycemia or committing suicidal case, find a cause. Always try to find cause. Is there any past history of low mood or family history? In a very non-judgmental way is very important. Sometimes when someone is drug addicted, living in the living in the street, okay, in that case, you have to ask about few things like cannabis, alcohol, which is very important. And in this case, as we are discussing the paracetamol case, in this case, you can say, yes, we'll do liver function to check some blood parameter and liver parameter intermittently to check that everything is going fine. There is no any unexpected consequence is happening, okay, until the point of complete washout of the medication. Then query, check the understanding. I mean, summary is not needed, the typical one. You can check the capacity. Did they understand? Did they avoid the risks of benefit? Not staying in the hospital? These things is very important, yeah. And motivate them and contact the number with the mood doctors or arrange a quick chat or meeting with the mood doctor. This is how you can end the scenario. This is the, guideline, a nice guideline saying this type of approach in this type of scenario. Always, validate their feelings as if what they did completely fine in a very non-judgmental way. Unfold it gradually. Don't rush and hurry at the very beginning. Once patient build rapport, submitting their trust on you, then we can speed up your conversation. But starting should be very smooth, very slow. Active listening. Yes, active listening is very important in this type of case. When you will let them speak, they will probably tell everything. Okay, just nod your head, ask few questions to dig deeper. That's fine. Management of overdose, you already said. In this case, liver function checking, checking the psychosocial intervention. Okay, their social impact, with whom they are living with, what they do, their any mood problem. In this case, depression is there, so checking is very important. Risk assessment, which was completely, under discussed, during the calibration by Henry. So risk assessment is very important, pre, during, and after, and also any past history of depression or any family history of that kind of problem or anything like that. You have to septinating. Septinating means, in this case, retaining patient in the hospital, arranging a quick chat with the mood doctor. This is actually septinating. And apart from this, if the patient has any low mood along with some financial issues, homeless, in that case, you have to involve the social workers. This is also part of septinating. Confidentiality, yes, it should be the top. And definitely, before starting, always give reassurance. What we are going to discuss, everything would be confidential. No one will know. And we are not, by the way, going to judge you. Okay, we are helping you to come out of this trap and situation. This is how you can end up and start and end up the scenario. If there is no question, we can move to the LCC. Any questions from anyone regarding this suicidal case or any suicidal case?
Do we need to ask about alcohol, smoking, and driving in this scenario?
No, driving is not important, but smoking alcohol. If there will be something that patient, there will be something is there. So probably patient will say something. But in this case, you can say, I can come to know that from the case that you were low you are in low mode for the last few months, okay. And they will say something, doctor, I'm homeless or drinking excessive alcohol to remain free or stress-free. They will say something. And by the way, once you got a handsome amount of the risk factor during checking pre, during, and after assessment, I don't think you need to go in every detail of the smoking, alcohol, cannabis. If there is nothing, in that case, you have to seek for that. And in this case, patient have enough clue. Patient is feeling low, guilty, broke up, financial crisis, everything is there, lost their job. So I think this is pretty enough to take the assessment. But in a case where everything seems to be vacant, there is no other risk factor, but I have to come up with at least something, why and which factor actually precipitated them to go for or take this kind of life-threatening decision or suicidal decision. In that case, we have to.
Okay, thank you.
Okay, and welcome. So if there is no questions, we would like to move to the second scenario. Dr. Sadia, are you with me?
Yes, I'm here.
Okay, fine. This is your LCC on the screen. Your 5 minutes preparation time starts now.
Okay. Okay, let's start.
Fine. Okay, fine. Your time starts. Yeah, start please.
Okay. Hello, I'm Dr. Rahman, one of the doctor in this general clinic today. Are you Mrs. Ellen Watson, 63-year-old?
Yes, doctor. Mrs. Allen Watson, 63.
So how may I address you?
Mrs. Watson is fine.
Okay, Watson. So, okay, today I will talk with you about your health condition and I will examine you. Is that all right?
Yes, doctor.
Okay. So, what's bringing here today, Mrs. Watson?
Well, doctor, for the last few weeks, I have been going through shortness of the breath, doctor. Initially, I took a number of medication and antibiotic. Nothing worked well. And my GP thought it could be something different rather than viral infection or seasonal flu. That's why he referred me to you, doctor. So please help me.
Okay. Okay, sorry to hear that. So, for how long are you having this?
Uh, it's been for the last 3 weeks.
For last 3 weeks.
3 weeks, yeah.
Okay, is it the first time?
I have shortness of the breath. It's been on and off, but this time it's really severe and out of my capacity, doctor.
Okay, sorry to hear that. So, do you notice that your softness of breath is increasing day by day?
Yes, I think so.
Okay, so, okay, do you notice anything that makes your shortness of breath more, like any exertion or any walking, anything?
Initially it was not, but now it is. I did notice when I'm just walking for a few yards or just staring to go to the rooftop, and during that time, yes, I did notice. I have to catch my breath on and off. Yeah.
Okay, I'm sorry to hear that. So, how many steps you can walk without stopping before your breath to stop you?
Sorry, I didn't get that last question.
How many stairs you can walk before your breath stops?
Yeah. I mean, now 5 to 7 stairs is really tough for me, to be honest.
Okay, I'm very sorry for your suffering. So, do you notice anything that makes it better, like any rest or any position?
No, I mean, to be honest, I mean, I took number of medications prescribed by my GP, and I'm trying to find any relieving factor, but to be honest, not. That's why I'm here.
Okay. Good. So, anything apart from your shortness of breath, do you notice anything like any cough?
Yeah, cough is always there.
So, for how long you're having this cough?
For the same duration, doctor.
Okay. So, do you notice is it wet or dry? Any
I
flame?
think it seems to be void. I mean, it seems to be dry.
It's dry. No
It's dry.
flame.
No,
Okay. So, do you haven't noticed any blood coming during your coughing?
interestingly, my GP asked me the same question, but I did not, I mean, find anything like that. No.
Okay. Okay. Uh, so, did your cough wake you up at the night?
Yes, doctor. Terrible. And it's been happening for the last, 2 weeks. And for this, I can't sleep properly, to be honest. Every time the cough is coming, it seems to be not stopping. Always there. Once the cough started, it just in a bout way.
Okay. Sorry to hear that. So, anything that makes your cough less? You noticed anything?
My GP give me some cough suppression. I feel better, but not completely cured. Yeah, I still, yeah.
Okay. I understand. So, do you have any chest pain?
No,
Okay. Any racing, pacing of your heart?
racing pacing, yes. Particularly during climbing or taking some, step during that time, yes, I feel. And even the period of, coughing, I feel some racing pacing as well.
Okay, understand. Okay, do you have any leg swelling? Your both legs swelling? Do you notice anything?
Mm, I think my stocking seems to be tighter. I'm not sure. You can check it, doctor.
Okay, I'll check then. Okay, so do you have any raised body temperature?
Yes, for the last few days.
So for how many days?
I think it's for 8 to 10 days, doctor. Yeah, it's not really always. In the just night time, I feel something. The fever comes up. Okay, then during that time, I feel feverish. Other than entire day is completely fine, normal.
Okay, can you do you measure? Can you tell me the heart core temperature?
It was last day. It was 101 night.
100 and all. Okay. So do you have any weight loss? Weight change?
I don't think so.
Okay. Okay. So, are you getting pale day by day, or does anyone say like that?
No, my husband didn't comment on that, but he was saying uh, that I'm completely looking ill all the time. Yeah.
Pale. You are looking pale.
No, looking ill all the time.
Okay. Sorry to hear that. Okay. So, do you have any dizziness from standing in sitting position? From sitting position?
I don't think. No.
Okay. Okay. So, how is your water work?
My water was fine.
Okay. Any change in recent time? Any frequency?
I don't think so. No.
Okay. Any your how is your back passage?
Ball works. Ball works is
Yes.
also fine.
Any tight or loose motion?
No.
Okay. So can you tell me, do you have any known medical condition that I should know?
I have diabetes, and I have also, doctor said, GRD, something like that.
GRD.
Yeah.
Okay.
There's some acidic condition, as
Yes,
probably you can relate.
I
Yeah.
understand.
So these are
Okay.
the two conditions I do have.
Okay. So for how long you're having this?
My diabetes has been for 10 years, and my GERD it's been for 2 years.
Okay. So is your diabetes oral control?
It seems to be because last time they measured it was, 6.2.
Okay, understand. So any high blood pressure, but or any apart from this, any medical
Um,
condition?
Recently, I forgot to mention one thing. Just 1 month ago, I have been diagnosed with high blood pressure, and
Okay.
they started medication. Yeah, I'm seems to be fine. Okay, the blood pressure is also is controls. Yeah,
Okay. So okay. So do you have any hospital admission before or any procedure done?
no, just I have outpatient department consultation, but there is no actually inpatient admission now.
Okay. Can you show me your medication chart?
Okay, right now I'm taking proton pump inhibitor. I'm also taking metformin 500 milligram,
Okay.
morning and night times. And for my high blood pressure, I'm taking olmesartan, okay,
Okay.
in
Okay.
10 milligram. Yeah,
Okay. I understand. Okay. So do you have any same medical condition that runs in your family? Do you know anything?
my father had a stroke and high
Okay.
blood pressure, and
Okay.
my mother had asthma.
Okay. So do you have any asthma or any softness of
Mm,
breath problem in your childhood?
no, I don't think because I'm pretty fine. There is no allergies in my side. I don't
Hot.
know. It might be, but I'm pretty so far from the best. Past history. No, no.
Okay. So do you keep any pet in your home as a hobby?
Yeah, my pet is there, but it seems to be for last 20 years.
Okay. So which pet you keep?
Yeah, cat.
Okay. Okay. Understand. Any bird or any
No,
pigeon? Okay. So do you have any recent home modification in your home?
no. I'm living in the same home for the last 20 years.
Okay. Any change in your office? Or sorry, what do you do for your living?
Um, I'm actually I'm a consultant in a software firm, and it's
Okay.
actually home-based work, so I don't have to go to the office daily. So I'm doing remote job actually.
Okay. Okay. So understand. Okay. So I'm asking you some personal question. Is that okay?
Yeah,
Do you smoke?
I used to. I quit long before.
Okay, I understand. So can I examine you?
Yes, you can.
Okay, at first I'd like to start with a short single examination. At first I'd look to the hand if there is any clubbing present or not.
Okay, you want to check the hands.
Okay, okay. So then I would like to check if there is any palmar edema or anything present in the palm.
Palm. Palm is fine completely.
Okay, so after that I'd like to check flapping tremor is present or not.
Mm, no flap tremor.
Okay, then I'd like to check the uh, uh, is the vitals present here? Is it okay?
It's the same
Okay.
as like outside.
Okay. So after that, I'd like to do for if anemia present or not in the eyes.
Mm, patient, there is no anemia, no jaundice in the eyes.
Okay. So after that, I'd like to check if there is any bipedal edema present or not. I'd like to press over the medial malleolus above. Okay. So is it bilateral in the left leg also?
It seems to be, doctor.
Okay. So after that, I'd like to do examine the lungs. I'd like to do auscultation.
So this is your auscultatory area. You have to, give me the comment where and which area you want to check. Based on your
I'd,
request, I will change the area. Yes.
I'd like to check the all zone, upper, middle, and lower. At first, upper.
Yeah, maximize your microphone sound. Hopefully, we will see the sound, right? Then
Okay.
left.
Okay. 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 Okay.
Mm-hmm.
Then the
Then,
other one, other side. Okay.
mm-hmm. Fine.
So after that, I would like to take the heart. I'd like
2
to
minutes
take.
left.
I'd like to take the heart sound if there is any pulmonary hypertension present,
So what
and
do you want to check in the heart?
if there is any parasternal heave.
It's really hard to appreciate. You have to rely on the auscultation.
Okay.
Mm-hmm.
I to take all the area.
Fine. Maximize microphone. You're supposed to hear it. Let me know when you
Okay.
want to.
Okay. Okay.
Okay. Should
Okay.
I
After
stop?
that, yes. Yes. Stop. Another one. Then the tricuspid area. Okay. Then pulmonary area. Okay. Aortic area. Okay. Okay.
Mm-hmm.
Can I hear the pulmonary area again?
Sure.
Okay.
Time up.
Okay.
Sorry. You have 1 minute left.
Okay. 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 So after that, so what is your concern?
So, doctor, what's wrong with me? I mean, is it like my mother's asthma problem that actually came back to me?
Okay, Mrs. Orson, after talking with you and examining you, I think the condition you are having, it is called heart failure. Don't bother about this medical term. Actually, your the heart is not working properly due to some medical condition you are having. Probably
Mm-hmm.
it could be some sorts of your gate in one of your gate in your heart is affected, and that's why you are having this type of shortness of breath. Are you getting my point?
Okay, doctor, I mean, is it treatable?
Okay, so at first the condition you are having right now, the heart failure, we can treat that, treat it, and so that your breath
Time up.
less.
Complete
Okay.
15 minutes time up. How does it go, Dr. Sadia?
Okay, it's go. Okay, but I couldn't manage the time.
Anything you could have done differently if you think that you get the case freshly, and now you have the second chance again. So what you would think you could have done differently?
I think I should examine first in a very early way.
Okay, fine. Okay, before going to the feedback part, I would like to interact with other candidates. What you were guys thinking as a differential in this case? What are the things Dr. Sadia could ask in a prompt row in the history part and also in the examination part can do in a prompt row. So these things is very important to know and just to know your view. So any differential from your side? Then I will start the feedback now. Anyone has any important comment?
Regarding
The
the, sorry.
Sorry. Sure. Dr. Sobi? Okay. Anyone? Dr. Sobi, probably you're trying to say something. Yeah, the entire objective is to ask these questions at the end of, every case, just to get to know, about your thought, okay, what you're thinking, because we are just practicing. One candidate is getting the chance to practice with me, right? But I would like to connect with other, okay, as a differential, you had the whole calibration, history and examination. Probably there is something running in your mind, okay, just share with us in the comment section or unmute yourself, okay, so that we get to know that how much you did get, what is actually your thought, and then we can discuss why these things actually as a differential is justifiable or not, then we'll discuss everything. Okay, and there is no comment. Fine.
Doctor, examination by checking the abdomen for the liver.
Dr. Hassan, yeah, an examination.
Yes.
Dr. Hassan, I did not get you. I mean, any examination? Sorry.
Abdominal examination.
Okay, examination of the abdomen you want to do, right?
Yes.
In the abdomen, there is nothing significant. Normal.
Okay, and then I will check the lymphadenopathy.
Okay, fine. It's very important. Okay, there is no lymphadenopathy.
Okay, then the drug history and the family history, nothing in that. And occupation, or get deep in it.
Patient is a software engineer, as she said. Okay, she does remote job from home.
Okay.
Fine. Okay, so I did not expect that this case recently the short case is coming in the long form. I mean, recently, as you will probably saw that bronchitis, ILD, and heart failure, acute exacerbation of the COPD. These short cases just coming in the long form. I mean, long clinical consultation. And in this case, exactly, if you look at the patient's pattern, shortness of the breath, patient probably in tachypneic state. Look at the hands; it's very well-defined clubbing, and Dr. Sade probably did miss it.
Yes, I actually
Yeah.
missed it.
Oh, okay. So I also forgot to go to the crossing part. It's supposed to be, but I started the feedback part early. Okay, no problem. We're going to the feedback part early. So, and patient has bilateral pedal edema. And the cough is dry. The cough is dry. If you auscultate it carefully, which is very obvious in this case, okay, I'm pretty sure the sound is very well defined compared to the real patient. If you look at and here the crackles is both on the basal side, right? Both on the basal side. The middle and upper part is completely fine. So it seems to be, if you just connect one thing, clubbing, it seems to be only one diagnosis. This is acute exacerbation of the interstitial lung disease. Okay. Yeah, the heart failure can be good differential, and in fact, it can be a good differential in this case, in the second position. But only one thing, if you just look and connect the clubbing along with dry cough and in fine crackles biphasally, this is enough to justify ILD. And by the way, in heart failure, usually patients should have some pink color sputum, right? Productive cough would be there. But in this case, patient has only dry cough, completely dry cough. So this is actually interstitial lung disease. Now, coming from the very beginning, okay. So discussing history part, Dr. Sadi, I mean, the things I did notice, you took a very good history in a well-organized way. And the history part was completely fine. But I also amazed by the history of home renovation, any recent change in the home and office, any bed. These are the potential history, particularly in a case of shortness of the breath. Trying to exclude the asthma or extensive allergic alveolitis. Okay, you did that. And I also did notice that from the previous session as well as in this session, you started examination a bit early. In this case, particularly, yeah, it happened a little bit late, but starting 9 to 10 minutes is not, bad. In this case, you did examine everything, and I was at once that you got the diagnosis when patient has some clubbing, well-defined clubbing, and with some basal crackles, which is fine. But during examination, you did not check the, crackles nature. You did not stop me and can you give me a cup? I was expecting. An examiner will also expect in the real exam. Okay. When you got any crackles, one thing you have to do, okay, stop the patients, can you give me a cough? And by the way, when you offer the patients to give a cough, there are two information you may get. If you are dealing with bronchitis, in that case, patient will probably offer some sputum pod. Will just request for a sputum pod or probably seek for any tissue paper, because the the sputum is really productive. They cannot resist or just keep it, okay, in the mouth. If the case is really bronchitis, is okay. But in case of ILD, another thing is noticeable, what we did learn from the bedside practice. When patient has ILD, if you offer them to cough, if they start and give one cup, they cannot, resist the second one. There would be bouts of cough, probably third, fourth, and fifth. They don't have any control over their coughing episode. Okay, when they intentionally do one, they cannot resist the other. 3, 4, 5. This is a big clue, okay, by the way. And definitely you have to rely on other findings. I'm not saying you have to, solely have to rely on this, coughing check. No. In this case, patient has, long history of the cough episode, but this time it's been for a while, 3 weeks. And patient also give the history of dry cough, right? It's on and off, but this time it's a little bit different. It means the acute exacerbations, patient in acute flare state. That's why patient, according to the patient interpretation, is different. But patient said, yes, it had in past. And in this type of case, the history is important. Occupation, as you already asked, and there are any drug history, particularly any drugs like methotrexate, any chemotherapy. But in this case, this type of history was absent. One history you have to check very important, very vigorously. Any joint pain, any muscle pain, any rash, which is completely missing to exclude any connective tissue disorder. Okay, because in exam setting, they will actually seek for that. In an elderly patient like this, patient might have polymyositis, dermatomyositis, or Sjogren's syndrome. So that's why joint pain, rash, muscle pain, dry mouth, any red eye, this type of history should be sought. That was missing. One thing I did notice in the back passage, the term back passage is not a good term. I would skip that. Rather, you can say, what about your bowel habit? This is very gentle word. Back passage is seems to be not appropriate. Okay, you can say the bowel habit. What about your bowel habit? You can ask that. Yeah. So as we did not go for the crossing part, so that's why the things, okay, Dr. Sadian. So in the concern meeting part, I also did notice this. You just made the concern with the heart failure. What if, okay, if you just use the broad range, when you are not sure, still you can end up with good marks in the concern meeting part. The concern meeting part could be, we're thinking a range of possibilities. When you are not sure in PACES exam, but you were thinking number of possibilities could be very safe approach. Go with this approach, okay? After talking to and after examination, we are thinking a range of possibilities. It can be chest infection, for example. 2, it can be scarring of your lung tissue. But we have to do some imaging, X-ray, and especially scan and blood test to confirm that. Once the test will come, we'll form a team of doctors, including the chest specialist, okay? Then we'll be in better position. But right now, I would like to give you high fluorescence. Admit you. Admit you is very important. Patient is in very, distress. And you did not say that. And do the patient, they need admission or not? You have to mention in the concern meeting part. And I always say in the concern meeting part, at least this 5 part need to be covered. Otherwise, every concern would be incomplete. What are the 5? Admit. In this case, you have to say, do they admit or not? Definitely admit or not. And in this case, I don't know, did you notice that patient started AC inhibitor as well for the hypertension? So AC inhibitor can cause dry cough. And as a receptor, if you mentioned that can have some contribution, but we have to find out. Or in the third position, it can be. Although the counterpoint is clubbing, but still, you can think a range of possibilities. The medication you are taking, it can be chest infection or scarring of the lung tissue. We have to admit you. We'll give you some oxygens and also run some investigation. Then we'll form a team of doctors. So drugs, in this case, what are the drugs? We don't know. We cannot say definite management, but you can say we'll give you some oxygen. Oxygen, in this case, a medication or drug, okay? Then multidisciplinary team or investigation, I for investigation. In this case, you have to see special scan, X-ray, and blood test, and T for treatment. T for treatment. And then in the crossing part, as we did not go for that, but there are few possible common question would come into the conversation or crossing. The most common questions would be, okay, what are the good prognostic features or bad prognostic features of ILD? Okay, in LCC crossing, they will ask that. Okay, so poor prognostic feature when patient is in elderly stage, extreme age, multiple radiological lesions, exercise-induced desaturation. Okay, so there are three you can mention in this type of case like prognostic features. Okay, extreme age when patient is elderly, it's also a extreme parameter of prognostic features. Extensive lesions in the X-ray and imaging extensive lesion. Okay. Exercise-induced desaturation. This is also a poor prognostic features in an ILD patient. Then examiner also asks sometimes, what are the good prognostic features? Okay, steroid responsive, right? Non-specific interstitial variety is a good prognostic features. Is a good prognostic features. And what would be the treatment? In a case of ILD or COPD or bronchial asthma, you can use a complete default treatment that would be applicable for every type of case, at least to settle the patients. Okay, then you can go for some definitive treatment. So what are the common format you can use in a patients like ILD, COPD, or bronchial asthma? Just hold on. So the common treatment can be O, A, B, C, D, E. Okay. So in every case, you can, when patient has shortness of the breath, so oxygen is a treatment, right? High flow oxygen. It can be high flow or control flow. In a COPD case, it's control flow. As patient presented with acute severe attack, so definitely, probably there are underlying some key infections, right? In that case, you can prescribe, would like to go give you some antibiotics, as I'm suspecting underlying precipitation can be for, some bug infection, right? Before bronchodilator, salbutamol, dilator. C for corticosteroid. In this case, we can give that corticosteroid. And in bronchiectatic case, it can be C for chest physiotherapy as well. It depends upon the case. D for diuretics. In this case, as you can see, patient has pedal edema. So it requires also diuretics. And E actually is not applicable in this case. As for surgical, and as we know that in ILD case, there is an other transplant option is there. Lung transplantation is the last options to treat the conditions. So this other treatment option you can mention this in this scenario. So Dr. Sandia, do you have any questions?
No.
So what I would say when patient has clubbing, just one thing, just connect with the lung findings. If there is any crackles, yes, crackles is there. Is it bibasal? Yes, bibasal seems to be ILD, but it can be, the crackles can be in different location, right? It can be in the middle and also basal zone. In that case, you have to think about two things. Okay, let me just draw in this part. Patient has crackles. Just connect one thing. Patient has crackles plus clubbing. Is it uniphasic? Uniphasic means only during inspiration or expiration. This is uniphasic. Or biphasic if it is in both phase. If it is in both phase, this is bronchiectasis. And in bronchiectasis, there will be some wheeze. Even you can hear without stethoscope, right? Uniphasic, usually In one phase, mostly in the inspiration. And during inspiration, actually in the end part of the inspiration, typically in the end part of the inspiration, end inspiratory, fine crackles. This is ILD. This is ILD. And in this case, yes, antifibrotic medication we have to prescribe pirfenidone, nintedanib. These are the options we can prescribe in this type of patients. The total learning point of this scenario to set here as a practice case. Recently, you probably noticed that there are lots of short cases coming and calibrating in a long form. Acute exacerbation of the bronchoasthma, COPD, bronchiectasis, Parkinson. There are lots of short cases, just they're changing the calibration and putting them into the long form. So that's why always be open. Open because every short case can become in the long form. Any questions from anyone? Dr. Hassan, yeah.
For clubbing, it is only idiopathic or could be secondary if there is clubbing?
In this case, the clubbing is idiopathic. In idiopathic, we don't know the reason of the clubbing in ILD. Okay, so we don't know. We don't know. And in elderly patients, it can happen due to long-standing hypoxemia, right? So in ILD, we don't know the reason of the cause of clubbing. It happened due to long-standing hypoxemia. So cause is unknown, but the cause can be known case. It can be drug-induced. It can be some disease-induced. Okay, and based on this cause, there are two type of things may come into the equation of discussion. Okay, there are few causes that can cause interstitial lung disease in the upper jaw. Okay, so in that case, there is a mnemonic is there, chart, right? Chart mnemonic. There are a few causes. Those are cold or minor vicus. Those have steatosis, right? Asbestosis, ankylosing spondylitis, radiation, TB, sarcoidosis. These are the upper or apical region causing interstitial lung disease. Yes, there are some causes out there. We call it basement. Basement. These are another acronym you can use. B for bleomycin, A for asbestosis, right? S for SLE. S actually means SLE, E for ethambutol, and me for methotrexate. These are the drug. All a drug can cause interstitial lung disease in the baseline. So in this case, patient does not have any drug like that. Okay, so we cannot say it's drug use. You can say this is idiopathic. Mostly the cause in this case is idiopathic pulmonary fibrosis. Dr. Hassan, did you get your answer?
Get you, but for the secondary, there is no clubbing. For secondary cause.
In the secondary, the clubbing may develop later or absent, but actually in idiopathic, the clubbing is more prominent. Yes.
Okay, thank you. Thank you.
And the prominent history would be the drug. In that case, you have to explore that. And just bending the case just to dig deeper so that you can think beyond the normal case. For example, just hold on. Just hold on. This patient has actually clubbing and patient has long-standing COPD. But patient now developed shortness of the breath and on examination you got bibasal fine crackles. What would be your thinking? Patient is a known case of lung carcinoma. Dr. Hassan or anyone?
Doctor,
COPD.
Can you repeat?
Yeah, patient has no long-standing COPD, known case of lung carcinoma. Now patient presented with clubbing and shortness of the breath. On examination, you find bibasal crackles. Fine crackles.
Radiotherapy or chemotherapy induced?
Yes, radiotherapy induced.
Lung
Radiotherapy
fibrosis.
induced
Lung
interstitial
fibrosis.
lung disease. Yes,
Yeah.
lung fibrosis. So what I'm trying to highlight is that the obstructive disease may later on turn into restrictive pattern. Initially, patient has COPD. Okay, this is the primary disease. Then later on, it turns into lung cancer. Up to this point, he is fine. But as you started radiotherapy, with the time, patient may develop interstitial lung disease due to drug cause, and the whole pattern of the disease would be completely reversed from obstructive to restrictive, right? So that's why be open and just be open-minded. Go with your, format and structure, and you will go to the diagnosis. In this case, when I'm asking for differential, I did not get any differential list in the comment or in the microphone. I was just thinking, okay, why you were, this seems to be a little bit easy case in compared to the other case, but the expectation probably ILD is less common as a long case. That's why we are sometimes just stigmatized, or sometimes just program that is it's not common. ILD is not common as a LCC, it's probably common as a short case. So in cases, anything can happen. Any case can be calibrated in different way. Just be open and follow the normal basic. You will not miss. Yeah, thank you for joining. If any questions regarding this scenario or previous scenario, you can ask me now. With any questions from anyone?
Yes, doctor. I'm sorry. Joined late. Is this session recording for sharing, inshallah?
We'll try to because we have to upload it on the site, then we'll share in the groups.
Okay. Thank you. Thank you.
Thank you.